Synovectomy is a excision of the synovial tissue surrounding a joint. Tenosynovectomy is a procedure performed to surgically excise the tendon sheath, a layer of membrane surrounding the tendon. Synovectomy, carpometacarpal joint. The physician removes the synovial membrane from the carpometacarpal joint. The physician incises the skin overlying the affected joint. The joint capsule is incised to expose the synovium, the inner membrane of the articular capsule that lines the joint cavity. The inflamed or enlarged synovium is dissected away from the capsule and the bones and removed. A drain tube may be placed and the incision is repaired in layers with sutures, staples, and / or Steri-strips. A splint may be applied to limit movement. Synovectomy, metacarpophalangeal joint including intrinsic release and extensor hood reconstruction, each digit. The physician removes the synovial membrane from the metacarpophalangeal joint, releases intrinsic musculature, and reconstructs the extensor hood. The physician incises the skin overlying the affected joint and dissects down through the soft tissues to the joint capsule. The joint capsule is incised and the synovium, the inner membrane of the articular capsule that lines the joint cavity, is removed. Intrinsic muscle contractions are released by exposing the extensor aponeurosis and incising the fibers at their insertion down into the tendon with a parallel incision, while preserving the transverse fibers. The adequacy of the dissection is tested and adjusted before the remaining flap part of the extensor hood is resected. The incision is closed with running sutures and a plaster splint is applied to hold the metacarpophalangeal joints in extension but allow full movement of the interphalangeal joints. Report each finger separately. Synovectomy, proximal interphalangeal joint, including extensor reconstruction, each interphalangeal joint. The physician removes the synovial membrane from the proximal interphalangeal joint and reconstructs the extensor tendon. The physician makes a midlateral incision overlying the proximal interphalangeal joint, severs the attachment of the transverse retinacular ligament, and elevates the extensor hood. The collateral ligament and central tendon are identified and the joint is entered. The synovium, the inner membrane of the articular capsule that lines the joint cavity, is removed. The transverse retinacular ligament is relocated and the extensor tendons over the dorsum of the finger are repaired as needed and reattached to the joint. The incision is sutured in layers. Report each finger separately. Synovectomy, intertarsal or tarsometatarsal joint, each. Metacarpophalangeal joint, each. The physician makes an incision on the top of the foot over the small bones of the foot in front of the ankle. The skin is reflected to expose the tendons. They are divided and the soft tissue reflected to expose the bones. The synovium is removed by careful dissection. The bones are allowed back into their original position and the skin is closed with sutures. Synovectomy, tendon sheath, radical, tenosynovectomy, flexor tendon, palm and / or finger, each tendon. The physician removes the synovial membrane from a flexor tendon sheath, tenosynovectomy, at the palm or finger. The physician incises the skin of the affected finger on the palmar side in a zigzag fashion and exposes the flexor tendon sheath. Taking care not to damage neurovascular bundles, the sheath is excised, except for a small area in the middle of the phalanx sections. The synovium is removed as much as possible and the incision is closed with interrupted sutures. A compression dressing and supportive wrist splint are applied. Synovectomy, extensor tendon sheath, wrist, single compartment. With resection of distal ulna. The physician performs a synovectomy of the extensor tendon sheath in the wrist. The physician makes a curved, longitudinal incision over the back of the wrist, radial to the ulna. A longitudinal incision is made through the deep fascia and the extensor retinaculum, entering the involved compartment. Hypertrophic synovium is removed from each extensor tendon sheath. If an area of a tendon appears frayed to the point of possible rupture, it may be sutured to an adjacent extensor tendon above and below the damaged area. After completing the tenosynovectomy, the physician evaluates the wrist. If synovitis is present, the joint is opened and a wrist synovectomy is performed. The dorsal retinaculum is sutured back into place, deep to the exterior tendons. Closure is performed after a drain is placed. The wrist is held in a neutral position, the fingers in extension. Synovectomy, tendon sheath, foot, flexor, extensor. A synovectomy is performed to relieve pain in the active stages of disease before joint destruction. For this procedure description, the flexor hallucis longus, FHL, tendon was used as the example. The patient is placed in a supine position with a tourniquet placed around the ankle. The physician makes a 5 cm incision behind the medial malleolus and toward the navicular. The neurovascular bundle is retracted, revealing the FHL in its fibroosseous sheath. The reticulum is released to the level of the sustentaculum tali and the tendon is inspected. A tenosynovectomy is performed and the tenosynovial tissue is debrided. Any nodules are excised and longitudinal tears are repaired. The FHL is released until the retinaculum no longer prohibits its motion. The distal soft tissue is approximated and the skin is sutured closed. A baloney splint or cast is applied. This procedure will vary depending upon which tendon is affected.